Hello everybody, I'm Kevin Lambert, the paramedic practice educator for Mid-Vancouver Island, and we're here today at Victoria General Hospital to talk to Dr. Janka Hegedus, a stroke neurologist, and Alison DeWitt, a stroke nurse in the stroke assessment unit, about how to take care of people suffering from a stroke, perform a good FAST assessment, and perform a FAST VAN assessment as well. Let's go inside and see what they can tell us.
Hi, I'm Janka.
And I'm Allie.
And we're from the Victoria General Hospital stroke team.
Today we're going to be talking to you about the FAST VAN stroke assessment.
So I'll start with the F part of the FAST, so that stands for face. So what you're looking for is some facial weakness. One of the earliest signs of facial weakness is a slight flattening of the nasolabial folds. The nasolabial folds are these nice creases that Allie has on either side of her face. So they're nice and symmetric in Allie, whereas in someone who suffered a stroke, one of the earliest signs of that can be a slight flattening of that fold. Other signs can be a drooping of her eye, although usually the forehead is spared in a stroke.
So someone that has a very obvious facial droop, that would be considered positive as well?
Yes, of course. Those are just the early signs.
So next we're looking at arm weakness. So when someone has arm weakness, we get them to test for it. We get them to put both arms up, palms facing up. That's very important. And we ask them to hold it there for 10 seconds. Right now you can see that Janka doesn't have any arm weakness. If it were to be positive, you would start to see the arm drift inwards and down. The arm drifting inward is what we call a pronator drift. So right now this would be a positive A in the FAST screen.
So the next is S. S stands for speech. What we're looking for is any abnormalities in speech, whether it's slurring or difficulty naming or difficulty getting words out.
When we talk about speech, we want to make sure you understand the difference between dysarthria, which is a slurring of the speech, and aphasia, which is the difficulty naming. So we'll get more into the aphasia when we go into the VAN screen.
But either one of those would be positive for the FAST part. So the last part is the T. So T stands for time, and this is because with every minute that passes with a stroke, brain cells or neurons are dying. Therefore, it is very important to seek help as soon as possible after a stroke.
So what are the time frames for considering someone to be a hot stroke?
That's a good question. So right now, with the thrombolysis or the medication that we give to dissolve the clot, we can give it within 4.5 hours after the stroke onset. However, we do have newer technology that we'll discuss later in the video, which is called thrombectomy. We're able to fish the clot out from the brain, and we can do that up to 6 hours from the time of onset from the stroke, or even longer in certain jurisdictions when a patient has woken up with a stroke.
So depending on where you are, a wake-up could still be considered a hot stroke?
Yes, so you should check with your own stroke team to know what the time cutoffs are in your own area. Next, we will go on to the VAN part of the scale, and this is the part that will be newer for many of you. And so it's very important to review what VAN stands for. VAN stands for vision, aphasia, and neglect. And now we're going to talk through how to test for each of those.
So the first thing you're testing for with the V is vision.
So with the vision, what we're looking for is not whether a person can see, but where their eyes are directed. So when you're looking forward, you actually have two frontal eye fields that are directing where your eyes are trained. If one of those is damaged, then your eyes will be skewed in one direction or the other, and you will not be able to look straight ahead or look to one of the sides. So for example, if Allie here is looking straight ahead, but if she was gazing off to one side, and no matter what I did, I couldn't get her to look over at me, so oftentimes I call her name or I clap loudly by her, and if I was not able to get her to look over, that would count as a positive vision assessment.
One of the ways that I personally like to remember when you're thinking about gaze is that the person will be looking towards the side of their brain that's having the stroke. So away from the weakness if they do have weakness, and towards the injured side of the brain.
And that's because that part of the brain will usually be driving your eyes to the opposite side. So what's happening is that the other side that's not injured is driving your eyes towards the side of the stroke.
So next we're moving on to A for aphasia. And to test for that, we're looking for the inability to name simple objects. So when you're testing for aphasia, you'd want to find common everyday objects that someone that's older or a senior would also be able to recognize.
So some of these objects that we commonly use are things like a watch or a ring.
Something that you wouldn't want to use is a watch like this that someone might not be able to recognize. So looking for common everyday objects.
So no smartwatches.
Yeah.
But if you're not carrying anything, sometimes I find it useful to use a body part like a thumb or an ear, and then asking them to name those common body parts. If you're wearing a stethoscope, that's probably not a good idea because that's a low frequency word and many people might not know what that is called.
So what about the people that have word salad? Or what about if you showed them a pen and they said it was a frog? Would that be positive?
Yes, it would, because they're not giving you the correct name. So either it's an incorrect name or they're not able to give you any name at all.
So if someone wasn't able to talk, that would also be positive?
Yes, it would be.
Okay. And then the last part is testing for neglect. Neglect is one of the harder things to test for, and the way you test for that is asking someone to close their eyes, asking which side am I touching?
Left.
Which side am I touching?
Right.
So it's really important when you're testing for neglect that they have to be able to feel both sides individually first. So once you've confirmed that they can feel the right side on its own, the left side on its own, then you move into touch. Which side am I touching now?
Both.
Both. So neglect would be positive if she only felt me touching one arm when I touched both at the same time.
And the reason that happens is because your body loses its ability when the stroke is in a certain part of the brain, usually the right parietal lobe, to pay attention to double stimuli. But the most important part, like you said, is checking to make sure that they can sense in each body part separately before you do double stimulation.
So if someone couldn't feel me touching one arm, would I be able to test for neglect?
No, you would not. And sometimes neglect can be very, very severe, so someone wouldn't be able to pay attention to that entire side of their body. So if they were completely gazing off to one side and unable to pay attention to this, sometimes you can even show them their hand and they would not recognize it as their own. Now, it might seem like a subtle finding, but it's a very, very important one, because if you're not able to pay attention to one side of your body, that is very hard to rehabilitate. You can imagine if you were undergoing physiotherapy and you were constantly ignoring one side, you're not going to strengthen that side very well. So that was our FAST VAN assessment. So that one of the most important things to realize is that you only need one of the things to be positive and fast before you move on to the VAN assessment. And in the VAN assessment, how many do you need to be positive?
Just one.
So you need one from FAST, and then you move on to the VAN, and if one of those is positive, then your patient is FAST VAN positive.
And these are the people that we think might be at high risk for having those large vessel occlusions that we can treat with EVT.
And that is why it's very important to bring them to the right center with enough time to initiate this treatment or to transfer them if need be.
So that was a great tutorial from Ali and Janka on the FAST and FAST VAN assessment. And now I'm just here in CT with Ali. And Ali, I just wanted to ask you a couple of questions about CT scan. I was hoping maybe you could speak a little bit as to why a CT scan is so important for these patients with a stroke and the different types of CT as well.
Imaging, and specifically CT and CT angiogram, are really important when we're suspecting someone having an acute stroke. When someone comes into the hospital, whether it be by ambulance or walking in on their own, we want to get from the moment they enter to the CT scanner within 15 minutes. And when they come down to CT, we're going to do what we call a plain CT, or a CT without contrast, and a CT angiogram where we use an IV to inject contrast. We look for a lot of things when we're doing these images, but two of the big things we're looking for is on the non-contrast CT is if there's blood in the brain. If there's blood in the brain, we can't get that person TPA. one of the big things with the CT angiogram is we're looking for a large vessel occlusion, and that's what the Van scale is really looking for. So the people that have big clots and the big vessels in their brain, and that's what we can treat with EVT.
And when we talk about the CT angiogram, obviously that's when we inject dye in through the IV. So it's pretty important to have an IV started, and if we can do that en route, is that quite a help?
It's hugely helpful. Having a large bore IV, so 20 gauge, or higher, will really be helpful. It really helps us get from triage down to CT quickly, having that started en route.
And once we're in the CT suite, how long does it take to get a CT and a CT angio done?
It's very quick. Once we get them on the table and hooked up to the CT machine, it's minutes long.
That's great. Thanks for your time. Hey Janka, I was just wondering if you could help highlight some of the treatments that are available for stroke. So first of all, I thought we'd start off with maybe you could explain a little bit about TPA and why we're giving that and who benefits from the administration of TPA.
So TPA is intravenous medication. So it's a clot busting medication. We give it to people who we know have had a stroke in the last 4.5 hours. So someone would have seen them have the stroke, would have known that they were well 4.5 hours ago for us to give this medication. The biggest risk of that is bleeding. So we know that if we give it beyond that 4.5 hour mark, our chances of bleeding grows up, and that's why there's that mark. It usually helps with people who've had smaller clots.
Okay, and this is also part of the reason why we need that non-contrast CT initially is to make sure there's not already bleeding in the brain before we give the clot-busting drug, I
Exactly,
suppose.
because the clot-busting drug would make the bleeding worse. But based on just the plain CT head, you can give the TPA. So it can be given in sites where perhaps you're not able to do a CTA.
And with the CTA, we've learned that that will help us find the clot that might be causing the problem. We look for those really large clots, and I think that's sort of where EVT comes into play a little more, the endovascular thrombectomy. So maybe you could explain a little bit about why that therapy helps and when that would be used.
Okay, so that therapy helps with those large clots that are blocking off a large part of the circulation, and that's why those patients would be Van positive, is because other things are affected as well. And so what this can do is, in a minimally invasive way, you can thread a wire up through the groin, through the aorta, and up into the cerebrovascular vasculature, and put up a stent remover, which effectively pulls the clot out.
That's great. Thanks very much.
No problem.
Hey, Ali, just before we wrap up, I was hoping you could just answer a few common questions
Sure.
that sort of come up when we're taking care of these patients. The first thing is I want to just highlight the importance, and I'm sure you agree, of ruling out hypoglycemia as a problem as well with these patients. Can that be a stroke mimic?
Absolutely. It's one of the biggest stroke mimics we encounter, so it's really important as one of your first steps, even before proceeding to a fast Van screen, is checking the blood sugar.
Sure. Another question we commonly get is, how about people who have previously had a stroke, or somebody who has maybe weakness on one side already? Can these people be having a hot stroke still?
It's a really good question, and there's a lot of different things at play here, but when you're thinking about your assessment in the field or at the scene, if someone is having a deficit that's worse or a new deficit, then absolutely you should always err on the side of caution and proceed as though those were hot strokes.
Ali, sometimes people get a bit confused with regards to a decreased level of consciousness or GCSs that might not technically be a 15. Now, I think it's fair to say that if people can't speak, you would assess their GCS potentially differently, but what are we really looking for with a patient in terms of assessing them for fast or fast Van?
So to do a fast Van assessment, the patient has to be awake and alert and cooperative. They have to be able to participate in the exam. So someone that has a decreased or altered level of consciousness, you can't do these screens on those people. So with people with decreased or significantly altered level of consciousness, you would take them to the closest hospital.
And one last question, how about people who are intoxicated? We come across people like that fairly often. Can you do a fast or a fast Van screen on somebody who's inebriated?
It's another really good question, and you have to be able to do your best. If they're awake and alert and enough to cooperate, then do the best you can. If they have focal neurologic deficit. So if they have a positive FAST or a positive VAN, then it's always best to err on the side of caution and treat them as a hot stroke if they meet that FAST VAN criteria and bring them to the correct hospital.
Great. Thanks very much for your time. I think this has been a great tutorial on FAST and FAST VAN assessments, and I'd like to thank Allison and Janka for being here and helping us to understand how we can best take care of our stroke patients. So thanks very much for coming.
No problem. It was a pleasure.